Well, welcome everyone to another session of Conversations in Interventional Cardiology. My name is Frank Ng. I'm Chief and Co-Director of the Heart Center at UC Davis and one of the Associate Editors for JSCAI. I'm honored to represent JSCAI and Editor-in-Chief Alexandra Lansky. You can find us online at jsci.org and follow us on Twitter at myjsci. As you know, JSCAI is home of all the official SCAI documents. We're here today to discuss an interesting and important document that's published in JSCAI that's entitled Impact of Stenting on PDA Length, Curvature, and Pulsatile Deformations Based on CT Assessment. I'm joined by an esteemed panel of SCAI leaders and experts. Dr. Howaida El-Said is Director of the Cath Lab at Rady Children's Hospital at UCSD. Dr. Ziyad Hijazi wears many important hats. He's the chair of the Department of Cardiovascular Diseases in Sidra Medicine in Doha, Qatar, and chief of the International Patient Services. He's also executive chair of pediatric medicine at Wales Cornell Medical Center in New York. And last but not least, Dr. David Nykanen is co-director of the Heart Center and director of the Heart Cath Lab here at Arnold Palmer Hospital for Children. So thank you very much for joining us, everyone. I'm going to turn this time to Dr. El-Said to start the conversation about the paper that she senior authored, and we will be discussing the utilization and impact of CT on PDA stenting in congenital heart disease. Howaida, I know you have slides to prepare, so why don't you share your screen?
All right. Well, thank you for inviting me to be on this. I'm honored and I'm excited to present our data. So I'm going to talk about our paper that we published recently in JSCAI about the impact of stenting on PDA length, curvature, pulsatile deformation based on the CT assessment. So I have no disclosures. The aim of the study was to investigate the impact of the stenting on the PDA, the length, the curvature, pulsatility, deformation in patients with ductal-dependent pulmonary blood flow. The methods, it was a small group of patients. They were 12 patients who had CT imaging for PDA stenting prior to the stenting. 8 of those had a CT both before and after stenting. And this is in collaboration with the engineering group at Stanford, and they did these geometric models. So I'm going to explain those pretty quickly for us non-engineers, because it took me a while to understand exactly what they were doing. But basically, they start with drawing a center line and orthogonal segmentation. So the blue dots here are hand-picked, and the yellow basically connects the dots. The next is building the orthogonal contour, which is the yellow circles. This is forms the model for the vessels themselves, the aorta, the PA, and the PDA. They do this double oblique plane, which goes along the blood flow, and it's derived from the flow direction in the vessels. So given all of that, the parts that are easier for us to understand as clinicians is these images here, where you can see in the top here, this is a PDA before stenting. In systole is the orange, and in diastole is this purple. And this same PDA post-stenting looks completely different. Now, there's an important caveat here that the CT scans are not done immediately post-stenting. So they're done a few months later, which is pre the next procedure. They focus on the purple, which is in diastole, and they measure this arc length, which is 3D distance along the true center line, and then the curvature. And the curvature is where they take these dots and then they form a circle, and then they basically measure the curvature, and they measure it along the whole length. And then the effective diameter is measured. Mainly it's the smallest area, but it's measured throughout the PDA. These are showing the patients that have had the stent the CTs and pre-stenting. You can see this is the PDA pre-stenting. This is what it looks like after stenting. Here, this is another patient, this is a second patient, third patient. And so the theme is that the PDA looks very different, and visibly you can see that it's straighter and it's also shorter. So with their geometric measures, they actually showed that the arc measurement, which is basically this central line, pre-stenting was 18, post-stenting is 13, so your p-value is significant, basically documenting that there's significant shortening. And then the curvature was, you have the mean curvature and the peak curvature, also showing that the curvature is smaller, so basically it's straightened. So here is when you look here, this purple, this is a PDA pre-stenting, and so it's 10.5. Post-stenting, this is the PDA itself. This is actually the stent. This is an important example because in this case, the stent was longer, and I'll explain here that the stent actually had a kink, and I'll talk about that here. So what we noticed that if the PDA stent itself is very long, that's okay, so long as it's not anchoring in any surface. So if it's anchoring, like here, it's anchoring in the PA wall, because of the contractility of the heart around it, this area is going to become kinked and possibly can become fractured. We concluded that the PDA is shorter after stenting because it's a more direct route between the aorta and the PA. The PDA is straighter after stenting as well because of the longitudinal strength of the stent, but we found that there was no significant pulsatile deformation, neither pre nor post stenting. Practically speaking, how do we utilize CT? We do a CT on every patient who gets a PDA stent, and we use it to do several things. One is to determine where we're going to address the PDA. So we will model different routes of access, whether here it's the right carotid or the right subclavian or the left subclavian, and we look at how many turns it's going to be to get into the PDA, and we decide from that our access point. But also we do our measurements. So we measure along the curvilinear line, and then we measure a straight line, which here is longer than it should be. And we take those two measurements and we decide what length stent to put in. This is just really a pilot study for future collaborations to try to help us clinicians know what size, what length stent, not what size. So the length of the stent has always been a problem for all of us to predict. So we're trying to predict what length to use based on the CT scan.
Well, Howaida, thanks for introducing or explaining the paper. So I want to start the conversation with a question to our group here. Now, we know that there's a wide range of practice protocols regarding the use of CT for pre-planning. Question I want to throw out to the group is, do we need to do a CT on every PDA before stenting? And why not? And maybe what I'll do is, Howaida, you mentioned you do this on every case. So why don't you explain to us how you use it, but why do you need it for every case? Because we know there's some fairly straightforward PDAs where you can sort of see it based on echo. You'll know you need to come in from the neck, and the length is less of an issue. It may not be so torturous. Maybe we'll go to Dr. Hijazi after that, and then to Dr. Nykanen. Go ahead.
So I think this for us was evolving. So initially, we weren't doing CTs for everybody. We evolved into our practice of doing that. We found that by doing that, we do a lot of pre-procedure planning. So it actually shortens our procedure and also decreases our radiation overall. So even though you're doing a CT scan, we use the CT scan to determine the exact angles that we're going to use. For example, our AP is going to show us the branch of the PA exactly where we want it. And we pretty much have predetermined what size stent we're going to put in from before. So we spend a lot of time pre-planning, and so the procedures are shorter and the overall radiation is less.
Z?
Uh, Good morning, everyone. First of all, congratulations, Howaida, on this excellent paper, great presentation. And this is, obviously a novel way of thinking of things. My mind is simple. We do not do CT scans on PDAs. We do the echoes and we take them to the cath lab, and angiography helps us determine what size is stent and what length is stent. And I don't know now whether this paper will change my mind or not, because my question to you, so what? You do all of this fancy, great analysis. How does it impact your day-to-day practice? You mentioned that, it helps you planning, but I don't know. I think what determine everything is reality on the ground when you take the patient and you do the angiogram and you put the first stent, whether it's short or long, and then you take it from there. So I don't know if this will change my practice or not.
So we started with an approach which is very similar to Dr. Hijazi initially, and probably reflects my long history of training in the era of angiography. Now we've actually evolved to doing a CT scan on just about everybody for two reasons. I think one is that there's an incredible amount of variability in the morphology of the ductus. So I think having a 3D rendering helps me, in my mind, determine what's going to happen. Although I must say, using a floppy wire across the ductus gives me lots of information as we're going. But the second thing that I utilize it for, and rightly or wrongly, is that I don't ascribe to stenting every single ductus, and I do think that it helps me know when I've got a stenosis of the proximal LPA, if that LPA is inserting on the ductus or originating from the ductus, and then the ductus continues on to the MPA. So I think it helps me with that morphology. And honestly, I've turned down some ductuses. I don't stent every ductus. I think that there are some high-risk ductuses, and in that setting, I have given those to the surgeons, and particularly if they think they're going to need an arterioplasty, then I've sent them to the surgeons rather than having ductal material in there for their second stage operation. That's a practice pattern that we have, and I think that the CTs have helped. So we've moved to doing a CT scan on everybody, but admittedly, I'm still learning and trying to figure out the utility of that, because I haven't quite in my mind figured out whether I need it for every ductus, but we've taken to doing it just because of a volume of practice issue, and trying to learn about the utility, to be quite honest. I don't feel that it helps me very much in choosing the length of the stent pre-catheterization. I tend to do that with it roughly in mind, and then I look at when I straighten in the ductus out with a wire and try and determine it that way.
Yeah, so I've also not been doing them on every case. I've relied a lot on the echo person to tell me, based on their assessment, where the access point is best. So far, they've been correct. I usually take a picture before the wire goes in, as well as after the wire, and I sort of use that length after the wire goes in to decide what length to use. Howaida, you mentioned in the paper that on average the length of the duct is shortened by about 25%. So when you do these CTs, are you calculating the sort of the natural curvature, and then you do a direct bees line from the aorta to the PA and use that, or are you automatically taking that curvature and subtracting 25% to decide the length? How are you doing that?
That's a very good thing. But in our paper, we saw that the PDA shortened, but that was a few months later. So when you're putting it in, you can't predict how much shortening you're going to get from just straightening. That's the hard part. We tend to overshoot with the stent so that we don't miss any of the ends. The particularly problematic, and both ends are problematic in different ways. The aortic end is problematic because if you miss it, the stent drops into the aorta and it's very hard to cross again. Of course, you should leave the microcatheter in and all of that. But if you don't overshoot on the PA side and you miss that, it's hard to cross with another stent in the ductus. It's not like a coronary where you can cross it. So again, we've evolved. So we didn't used to, but we found that, why not? For us, it gives us more information. And then these patients, this procedure is a very critical procedure. I think we should respect this procedure because the duct can spasm, and even in experienced hands, we've all had complications. So the more information we get ahead of time, I think the more everybody's prepared. Like David has said, like I will talk to my surgeon and I'll say, I'm going to jail this PA. And then he'll say yes or no, or maybe I would particularly put my stent into that LPA that's going to get jailed and actually jail the RPA that's going to stay open with struts. And that's something we're looking at. But I think the more information we get, like for you and for Z and Dave, you all are very experienced. So it'd be easier. It's easy for you to go in and tackle it. But younger people are doing this procedure. And I think having them go in prepared with everything they need gives them the tools they need so that this procedure can be successful for people that are not necessarily as experienced. And there is a learning curve. There's a learning curve for everybody doing this procedure. And so I think this makes people a little bit more prepared going in.
Howaida, do you take an angiogram in the lab, or do you purely look at the CT? And so my next question to everyone is, if there is a discrepancy in either the diameter or the length of the PDA between the CT and angiogram, which one do you trust and why? Howaida, why don't you start?
So for the diameter, I'm going to trust the angio because the CT scan is done early. And after that, you have probably manipulated your PGE somehow. Either some people turn it off or turn it down. So the diameter, I'm going to trust the angio. For the length, I'm actually going to trust the CT because with the CT, I'm able to manipulate my image so that I'm not foreshortening it in any way. So I tend to trust the length of the CT. Like I really won't go shorter than the length that I predetermined that I was going to use from the CT scan. So I've learned and evolved to trust the CT for length.
So Z, you said that sometimes you use CT as well. So when you do a CT and you see discrepancy, how do you think through the differences in measurement?
Yeah, quite honestly, I rely heavily on the angiogram because it is action now. The CT, as Howaida said, you've done it probably hours or days before, and things could change. So we use the CT scan, obviously to look at the anatomy very well, to see the length of the ductus, and we have, pre-planning, right? But the actual decision-making process, everything is dependent on the angio at that moment. Similarly, for transcatheter pulmonary valves, we do the CTs, the MRIs, gives us, rough idea, but the final decision is instant when you are in the cath lab.
So Z, just a corollary question. So when you take your picture, do you also repeat the picture with the wire in there to see what the changes is with a stiffer system in place, or do you go by the dimensions without the wire?
Without the wire, I do the initial without crossing the ductus at all, because as we all know, spasm and changes the morphology. So I rely heavily on the angio before, and then once I put my first stent, then reassess based on the angio that I do after the first stent.
Can I ask a question, Z? You said after I put my first stent, are you always putting more than one stent?
If the ductus obviously is long, but oftentimes or most of the time it's one stent, but depending on the armamentarium I have in the cath lab, sometimes we may not have all lengths available on the shelf, so I end putting overlapping stents. So in general, I'd like to use one stent that covers both ends, sticking a little bit into the MPA, sticking slightly into the aorta. And if that stent does not cover that length, then, overlapping, starting with the distal with the MPA and then coming back more proximal.
Okay.
Yeah, I think that I would echo that. I initially started doing, when I started doing PDAs, I often would intentionally use 2 stents, which of course is not optimal. You run the risk of embolizing the distal stent. You run the risk of having problems. Of course, if the proximal portion of the stent ends in a curvature on the ductus, it can be difficult to get back across. So I too have gone to 1 stent, and perhaps that's where I've utilized CT a little bit, because if I can determine have an estimate as to the length of stent that it's going to take to cover the entire ductus going in, I'll take the preoperative angiogram. I will then make a determination as to what size of stent I would like to use, or I think I should use, knowing what the CT measurement was, or what the CT estimate was. The difficulty, of course, comes when you've got a straight wire across the ductus and then you end up with thrombus in the ductus or spasm and that type of thing, and you have to go very quickly. In that sense, I think the CT helps me, because I've now got the CT and my impression of the unstraightened ductus, and I know what type of stent I'm going to have ready on the table in the event that I have acute desaturation and I have to do something very quickly. Does it always work? No. Sometimes I have, I'm not covering the proximal end, and it's usually the aortic end, if I'm going to be short, that I don't cover. But I think it gives me an idea as to what I want to have the techs have immediately available. One question that I had is, has the tortuosity of the ductus changed or influenced your choice of stent based on that tortuosity? It doesn't for me. I'm curious, Howaida, if it's done that for you.
Yeah. So I would say we don't have enough data, right? So we are collecting data. So we're getting a bigger data set to be able to look at that. But my impression is, if the duct is very, very tortuous, you really have to use a longer length, because like what Frank was saying is, do you measure it with the straight wire, without the straight wire? When you put the wire in, particularly if it's a stiff wire, it's going to give you a false sense of shortness, because once you take that wire out, it's going to relax back, maybe not into the same complete curvature that it had, but it's going to relax back into some kind of curvature. And that's when you're going to miss the aortic end. And so initially, I felt we were missing the aortic end more often than now, because I'm not relying on. I actually almost don't do a measurement after I put the wire in. I'm pretty set from the CT that I'm not going to go shorter than X.
It's interesting. I'll take my picture, and before I even cross the ductus, and I have an idea what the length might be. Obviously, when it's tortuous, I'm wondering, it's usually between no more than 3 different lengths, because not every stent has every millimeter difference, right? It'll be 15, 18, and then 22, 23. So you sort of have an idea. I have them all on the table, not open, but ready. And then when I put my wire across, I take another picture, and then I can make a measurement. But I will admit that there have been times when, after you put the wire, you take a picture, and there is some spasm there, and you know that you don't have much time before you have to get the stent in. So definitely there is some value in knowing in advance what it is. I do find that I recently had a case where the ductus, instead of coming off the undersurface of the isthmus like a typical way, it actually came off the side of the aorta, taking a 90-degree turn into the aorta. And certainly that ended up resulting in us having to bring the kit a second time, because in spite of the angiogram looking like as if the stent was all the way at the roof of the aorta, because it's so high up, it turns out that there was another turn to the side, which we literally missed by 1 to 1.5 millimeters on the follow-up scan. So we had to go back in. So I do see there's value. I just wasn't sure what I needed on every single case. Now, I do think that depending on the center's expertise, confidence, the resources they have, that might alter how we think through things. We have a 20-year-old scanner, and radiation is high, and the quality of our scans aren't the most beautiful. I've seen some of your work, Howaida, and you guys have art, really, it looks like art because it's so pristine. So I think that those decisions may also be impacted by the resources, the skill set, the interest of the institutions. What do you think, Z?
I agree with you 100%. I think, technology nowadays with the novel, the new CT scans, the radiation is so minimum that we do not hesitate in any, not just, for PDA stenting, in any cardiac patient, if we need CT scan before the angio to make decisions, we go ahead and do them.
Okay, I think our 15 minutes almost up. Any last words from anybody of the panelists, Howaida?
Oh, thank you for this, and thank you for allowing me to explain the paper, because it is very engineer oriented and a little bit harder sometimes. But I learned a lot from it, and hopefully we'll have more to come.
Well, clearly this is an intervention that's becoming more and more common and being done by more and more people. So certainly we're still learning a lot about what can we optimize to make the procedures, outcomes the best it can over time. Again, I want to thank the Howaida, Z, and Dave for joining us on this conversations. Thank you very much for your time.